Good afternoon, everyone, and welcome. We will go ahead and get started with a poll, and we'll run it for a couple minutes, and then we will see you back here on the other side. Good afternoon. We welcome everyone to our webinar. CMQCC is California's Perinatal Quality Collaborative, and we are honored to play that role. We are here to support you, California hospitals, in the work to move beyond implicit bias training, deliver respectful and equitable care, and end racist practices. There is much work to do, and it is very clear it is not an option. This work necessitates us all to participate and to be accountable to the patients and each other. I'm Christina Oldini, hello, a former labor and delivery nurse of over 19 years and a proud native San Franciscan. And for the last 4+ years, I've been at CMQCC as one of the program leaders. While this webinar was intended for California hospitals, we want to welcome all of our guests today. There is the possibility this is your first webinar with us. We are known for our maternal data center, our toolkits, and our collaboratives. This work is very different. Today, you will hear about our team's internal efforts, the work we are committed to doing to support you all, and the story of one of the hospitals that participated in our Birth Equity Pilot Collaborative over the last 3 years. There's a lot to cover. Let's get it rolling with a look at the poll results, and then I will go ahead and introduce our speakers. So Gina, if you could bring that up, that would be wonderful. And then I'll go back to the objectives. Let's see here. Are you able to bring those up, Gina?
I'm sorry, I'm not. Marcy, can you please?
While they're doing that, why don't we go ahead and review our objectives for the webinar today. We want to provide an understanding about the current state of maternal health inequities in our state of California. We want to build knowledge regarding the use of the data center and specifically the stratification available with numerous clinical outcomes And then really we want to share the knowledge of tools and resources and the support we will be offering with our new initiatives for California hospitals this summer. You know what? We'll figure it out. We can always go back. So let's go ahead and meet our presenter. There we go. Here we go. So it looks about, wow, wonderful. Looks like half of the attendees, so half of the hospitals today on the webinar are already stratifying their outcomes in the data center by race and ethnicity. That's incredibly fabulous. You've also got patient experience measures and community engagement, plus goal setting. So we're really thrilled that all this is already going on in the state. And you will hear us talk about what other efforts you're going to be able to draw on over the next few months and years while you're doing this work. That's actually wonderful. Thank you so much for sharing and taking the poll. Okay, Gita, to start us off in a moment, our equity advisor and guide, Dr. Kendra Smith, formerly of both Stanford's and the University of Houston Schools of Medicine, now leading her own consulting firm.
This one right here.
Oops, can someone go on? I think Anita, can you go on mute? Thank you. Excuse me. Now leading her own consulting firm, a researcher devoted to healthy and equitable communities, will take you through our team's internal work, as well as the investment in focusing on equity-centered care. To speak to the striking supporting data for this work and the work ongoing at CMQCC, we welcome our clinical innovation advisor, Dr. Amanda Williams, formerly the director of maternity services at Kaiser, Northern California. Very importantly, Dr. Williams has served on the California Pregnancy Associated Mortality Review Committee, and we are very grateful. Excuse me. Our final speaker today, Reverend Dr. Candace Kelly, author, hospital chaplain, and chair of the Respectful Maternity Care Initiative at Memorial Care Miller Children's and Women's Hospital, Long Beach, will share the story of their work over the last several years. And closing us all out with our call to action is our executive director, Leslie Kowalewski, who prior to joining us at CMQCC, led the build out of statewide programs, including the Perinatal Equity Initiative. She coordinated state and local partnerships in her role as chief of the Maternal, Child, and Adolescent Health Division at the California Department of Public Health. Leslie spent 20 years previous to that role at the March of Dimes Foundation. We are so glad Leslie found us, and we thank our lucky stars we found her. Kendra, Dr. Smith, if you can come on camera, you're already there. I hope you're doing well today, and I'm going to hand it off to you. Thank you, Kendra.
Thank you, Christina. Doing very well today. Thank you and welcome to our webinar. We're so thrilled to have you here with us. As Christina mentioned, I'm Kendra Smith, and I've worked with CMQCC over the last few years on developing our equity-centered approach. As you've heard, CMQCC is an organization committed to ending preventable morbidity, mortality, and racial disparities in California maternal care. And we do this through a variety of things, including research, outreach, collaboratives, learning initiatives, quality improvement, of course, and through data, through our maternal data center, all to improve the health outcomes for mothers and babies. Now, we're excited to share the ways in which we've prepared and plan to roll out perinatal equity-centered quality improvement products and learning opportunities for our hospital partners. We firmly believe there is no quality improvement without equity, and we're committed to integrating equity in all aspects of our organization. For several years, there have been calls to integrate an equity-centered approach to QI. The persistent problems and deficits in the healthcare quality in the United States are well documented. With the increasing awareness and use of QI, there's also been greater awareness of the extent and the persistence of disparities in healthcare delivery outcomes, especially in maternal health. Many groups, including researchers, health institutions, interest groups, advocates, and birthing persons of color have advocated for using QI to address these persistent inequities in care and delivery outcomes. The National Birth Equity Collaborative, an organization founded by Black women focused on improving maternal care for persons of color, has called and created frameworks to implement anti-racist healthcare practices and tools to reduce racial disparities in maternal and infant care, and we agree. Regulatory agencies like the Joint Commission and CMS have added equity as an accrediting domain. So the call and challenge is clear, and CMQCC has been preparing to meet it so we can better serve our community, California, and our partner hospitals. Next slide, please. So as you know, CMQCC is well known nationally as a leading quality improvement organization. In California, in collaboration with California hospitals, CMQCC has been instrumental in reducing severe maternal mortality in areas of preeclampsia and hemorrhage, and developed quality measures that government and quality review agencies use. Over the years, we've seen an increase in some population and improved maternal health outcomes and disparate outcomes in populations of color, namely Black, Latino, and Indigenous across the state. We found that standardized patient care approaches were not addressing issues like microaggressions, racism, disrespect, and overall unequal treatment, and that this sort of one-size-fits-all approach of recommending the same care for patients who, in many cases, are not treated the same, actually perpetuated or widened disparities. And so this realization, informed by data, required a transition in our QI to call out and focus on equity explicitly. Next slide, please. In order to focus on equity and arrive at a place where we can support our hospital partners, we embarked on a journey of internal work. You might have heard that equity is a process and an outcome, and we believe this wholeheartedly. The process involves reviewing data to understand where disparities lie, investigating those disparities, utilizing diverse methods, looking at harmful policies and practices, and meaningfully involving those most impacted by structural inequity in creating and implementing new practices that will impact their lives. The ultimate outcome that we want to achieve is that things like race, gender expression, insurance, what part of town you live on, no longer determine a person's birthing outcome. That is the goal. And so to achieve our goal, we embarked on several opportunities to learn and grow our organization so that we may better serve our hospital partners. Those activities included the completion of an internal equity assessment that reviewed CMQCC programs, policies, practices, and norms. We created a birth equity team. Most of our team are listed here on this panel, on the speakers panel. And the purpose of this birth equity team is to ensure that equity is a key driver in programs that CMQCC puts forth, and that we're actively working toward equity together. We meet weekly to collaborate, create, and execute new products and initiatives, some of which you'll hear about later in this webinar. Finally, we created a birth equity agenda through an intensive process to develop how exactly CMQCC would go about and achieve our ultimate goal of equity in maternal care. As we progress in our work, one day we will not have to state that our work is equity-centered because it'll just be that way. But for now and into the foreseeable future, we will continue to be intentional about our efforts and tell all the ways that we're integrating equity into our quality improvement. Because again, there is no quality improvement without equity. Next slide, please. Additionally, we uplift the work of our colleagues, birth equity advocates, and birthing persons of color to ensure that voices are represented in our work. We agree with and elevate the cycle of respectful care, which is an actionable framework for respectful obstetric care designed through the feedback of Black patients across the US. We also have invested in focusing on equity-centered care for several reasons, but at the core, We know that equitable care, equity-centered care does not happen on its own. We know that unless we make a choice to elevate patient voices, it won't happen on its own. And we also want to create new opportunities for healthcare teams to engage with patients. Next slide, please. So before we go any further in this webinar, I want to describe what we mean by an equity-centered approach. Oftentimes, people will continuously refer to it with little explanation of what we mean. And so I wanted to go through this to make sure that we're all in understanding about what equity and what an equity-centered approach is. So by and large, equity in health is the absence of systematic disparities in health between groups of different levels. For example, at the center of what we're talking about when we discuss our biggest challenges in maternal health are poor birthing outcomes for Black or Latino or Latina and Indigenous birthing persons. We know these disparities don't exist because Black or Indigenous birthing persons are physiologically different or other deficiencies often assigned to stereotypical deficiencies assigned to these groups. We know that these poor outcomes are often preventable, and the data show that these are not just issues due to biology. And so this is an equity issue. These disparities exist largely due to implicit and explicit bias, not listening to patients, racism, the structure of the healthcare system, and other issues imposed on patients that can lead to catastrophic outcomes, including near misses and death. And the research has shown. And so the disparity, the difference between races is why this is an equity issue, because it's preventable and it does not have to be. An equity-centered approach is looking at policies, practices, and norms that might appear to be neutral, but in fact have disparate and harmful impacts on marginalized or minoritized groups. And so in order to do so, one has to have the data and be willing to first look at it and make an effort to understand why and how disparities occur if they are present. It's important to remember that we're talking about equity, not equality. We've heard from several providers, we treat all our patients the same. And I'm not here to argue individually on whether that is the case, because we know that there are so many dedicated healthcare professionals committed to healthy babies and moms. However, we know that the data show that in places where patients are experiencing these poor preventable birthing outcomes are not being treated equally. For this reason, attention to equity, stratifying the data CMQCC provides to all hospital partners to understand what is happening and addressing it for the patients suffering the most is absolutely needed. For this reason, additionally, the need to eliminate the we treat patients equally or the one size fits all and a rising tide will lift all boats approach is necessary, because these approaches are metaphors or aphorisms to QI that generally posit that by improving some aspect of quality, all groups will benefit equally. And that is not true, and it does not work. And so this brings me to CMQCC's new journey. As I mentioned, we've been working internally on this and we are ready to roll out. Although we're still the same CMQCC, we have new goals and directions, and we're working to grow our QI work to aid our hospitals in achieving equity. We want to address disparities in maternal care through concrete and accessible tools, which you'll hear about shortly. We want to test new models for patient care, and this is extremely important. We want to know what's working and what's not working, and we want to elevate both to help our hospitals understand and to have real life practice with what's going on. We want to analyze and address aspects of care that exist within clinicians and clinical staff's purview about widening and closing of gaps, and we want to integrate community engagement to elevate patient and community voices. With that said, I want to pass it along to my colleague, Dr. Amanda Williams, CMQCC's Clinical Innovation Advisor, but more importantly, a caring and compassionate OBGYN committed to moms and babies. She'll discuss with you data on maternal health in California and introduce you to some of the tools and resources CMQCC has prepared for you. Dr. Williams.
Thank you so much, Dr. Smith, for that kind introduction. And I'm excited to be with all of you who are committed to making maternal health improvement, especially across all different strata here in California. So I'm here to talk about where do we stand now in California and how can CMQCC help you on that journey. Next slide. So before I get started, I do have my disclosures, which are that my other job is as the medical director of Mommy, which is a venture-backed, tech-enabled pregnancy and postpartum wraparound services company aimed at elevating maternal health equity and supplementing traditional perinatal care, and as a clinical advisor for RiskLD, which is an obstetric alert and decision support software that is aimed at eliminating bias in data interpretation. So basically, any avenue I get, I want to be working on making maternal health better and in eliminating disparities in maternal health outcomes. So here's where we stand in terms of maternal deaths in the United States and in California. So the burgundy line is the United States, and the blue line is California. And you can see since CMQCC was started about 6 years prior to this blue line, we have traditionally been underneath underneath the United States in the state of California. And the United States does, of course, with the COVID pandemic, go up to about 23 maternal deaths per 100,000 live births. And so this is the body of work that needs to be done. Yes, we can be really proud of what we've done in California, largely in part to the work that has been done through these collaborations and through our maternal data center that we're going to talk about in just a minute. But the United States remains the worst place in the developed world for a person to have a baby, and we are committed to making that different. Next slide. So when we think about working in California, we're really doing sort of a pilot for the whole country. 1 of 8 births in the whole United States takes place in California, and we're an incredibly diverse state with rural areas, urban areas, mountain areas, farming areas. So we can see how different QI projects and how different efforts work in different populations. And we're very diverse by ethnicity. And you can see in here that though we live in a society where whiteness is most typically deemed the norm, when you look at births in California, that is the minority. The other thing that should catch your attention is that Black and Indigenous American Indian and Alaska Native birthing people make up just 6.5%. However, there are far disparate maternal deaths in these populations. So they certainly deserve special attention. Next. So, though we're doing really well in California, the question is, are the improvements that have been made in California for all of us? Next slide. And so when we think about the work that CMQCC has done previously, it really has been focused on clinical interventions and on standardized approaches to obstetric emergencies. So whether that's hypertension, cardiovascular disease, hemorrhage, low-risk C-sections, there have been improvements in all of those areas. And indeed, those improvements have been for Black birthing people also. However, the improvements have not been distributed equally. And therein we see where the opportunity still lies for equity focus in quality improvement. We need to think about community voice. We need to think about patient voice. We need to think about connecting to the public health system. We need to think about, where do patients spend most of their pregnant and postpartum lives? It is not in the hospitals. So we need to think more broadly if we're going to be making a real impact. Next slide. So I like this quote from MLK, because truly, of all the forms of inequality and injustice in the healthcare system, is the most shocking and inhumane. Because we all went into this with open, loving hearts, because we wanted to be better. We wanted to do better. We wanted to take care of patients. And I don't know any doctors or nurses or healthcare providers or midwives, doulas, anyone in birth work, lactation consultants. Nobody's doing this because they're a bigot. No one's wandering around with a t-shirt saying, I want to do wrong by this group of people. No, people want to do the right things. However, we live in a society that is just imbued with systemic racism. So it's not like folks are trying. I mean, maybe there are a few, but the vast majority of healthcare workers are not trying to be biased. This is part of the society we live in, and it has been systematically constructed. So it's going to take some time. We've had 400 years of slavery, Jim Crow, implicit bias. It's going to take some time to undo it, but you can all be part of this solution. Next slide. So this slide is from the 1840s. You may be familiar with the father of modern gynecology, J. Marion Sims, and his experimentation on the enslaved women that worked there, Betsy, Lucy, and Anarcha. We can keep the next slides coming in sequence. But this is not a problem of the 1840s, though the history of obstetrics has been deeply enmeshed with that of systemic racism. In 2018, the investigative journalist Nina Martin did a series called The Lost Mothers in ProPublica. At that same time, tennis legend and the greatest of all time, Serena Williams, came out discussing her experiences in childbirth. And indeed, we're still seeing it today, and we're getting more and more research that shows us that this is not just about comorbidities. This is not just about systematic approaches to obstetric emergencies. This really is about bias. And our recent study that had national media attention in the New York Times looked at the relationship between maternal and neonatal deaths and income, that even the wealthiest Black women in America and their babies were dying at rates significantly higher than the poorest white women. So we know this is not about money. It is not about education. We have a study to that end that came out of CMQCC a few years ago. This really is about bias and is about systemic racism, and there is something that we can do about it. Next slide. So here we are looking at US maternal mortality rates. So that's deaths, maternal deaths per 100,000 live births over 2018 to 2021. That's the latest data that we have. And unfortunately, going up, every single race ethnicity group is on the increase. And as you can see here, Black birthing people are at the highest rates. And I'm going to pause for 1 second. Whenever I talk about Black as a risk factor, what I mean is not a certain percentage of some kind of DNA. What I'm talking about is exposure to systemic racism. And it's for those very similar reasons that Native American and Indigenous birthing people are the only other population who have been discriminated against in a similar fashion at these egregious rates. Next slide. When we look specifically at California, while the overall numbers are much lower, and you look at the scale on the left-hand side, the overall numbers in California are much lower, but these ratios across different ethnic groups are still so disproportionately showing the disproportionate impact on Black and Indigenous birthing people. So this is the slide that gets me up in the morning, that makes me do the work that I do, that inspires me to know that this must be better. And even though California has the best maternal mortality rates in the country, this is still wholly unacceptable. Next slide. So when we think about what is it that California is doing that is different, we have an incredibly strong perinatal collaborative, and you guys are all a part of that. So inside of CMQCC, we have the maternal data center that now is going California, Oregon, and Washington, and we have over 500,000 deliveries per year, which is 15% of all the births in this country, and almost every hospital in the entire state belongs to it. Next slide. What we do is we bring together hospital data, and thank you. And I know it is tireless and often thankless. Thank you to all of you who do the work of validating data. At the hospital level, we get birth certificate data, we get Department of Public Health data, and bring it all together and then package it back to you, the hospitals, so that you can do things like run charts, like stratifying by payer, what's happening with your commercial population, what's happening with your Medicaid or Medi-Cal population. How are you benchmarking off of other hospitals? I mean, I can tell you when I was inside of the Kaiser system, I would look at all the level 4 hospitals and set them up. Every single week, I would go through the process of looking through them and seeing how are we doing, and then stratifying by race, ethnicity. If we are just having overall good rates, that doesn't, it almost doesn't matter. If we have certain populations that are being left out, our work is not finished. And sometimes it really surprises you. And it can surprise you from one hospital to another, especially for people working inside of systems. And so this is all available to you, the CMQCC hospitals in California. Next slide. So when we think about where are the areas in terms of clinical maternal health outcomes, and my focus right here is clinical, but do put a pin in the work that needs to be done in assessing patient care experience in a stratified fashion also. But here we're looking at clinical outcomes, and one of them that is near and dear to everyone's heart is supporting vaginal birth and minimizing the NTSV, the nulliparous term singleton vertex, so the low risk C-section rates. And we see that our Black birthing patients do have the highest rates in the state, and that there is quite a bit of variation between different ethnicities. And in your hospital, it is worth knowing who are the patients. There are some hospitals in the state of California in particular where Black birthing people are not the highest rates, that it might be your Asian population. So it is worth knowing who your patients are and what those numbers look like. Next slide. Exclusive breastfeeding is another area, and this is coming from California Department of Public Health data, but there is significant racial disparity when it comes to exclusive breastfeeding, and what the supports are and interventions are that might work to support a particular population might be quite variable based on their race and ethnicity. Next slide. And while we spend a lot of time looking at the egregious mortality numbers, maternal mortality is thankfully still very rare, but severe maternal morbidity is not. We're talking for Black birthing people on the 1-2% level. So those are people you're seeing every month, if not every week at your hospital. And we can see that there is tremendous difference in terms of different races and ethnicities based on the CDPH data dashboard. Next slide. So what is it that CMQCC has done previously, and where are we going, and what are we doing next? So this is a list of some of our projects that are going on right now, and all of them have been imbued with health equity. And so first, just in terms of selecting projects, these are areas where we know there are significant disparities in iron deficiency anemia, in preeclampsia, in postpartum. We know that we are, for every one of these projects, getting communities involved. We want the communities impacted to be part of the design process. Oftentimes people will run an initiative and then get a little focus group at the end, or run something by a couple of people at the end. That is not what these projects are doing. In particular, in anemia, in preeclampsia, we're going first to the patients and getting input on interventions, on different tools being used. And we're so thankful to our leaders who are doing that work. We're also thinking about diversification of the workforce, and in our community birth partnership work, thinking about how do we involve our midwives to help support our birthing families and keep them safe and drive down C-section rates? How do we partner with doulas? There's so many different ways in which we're thinking about inclusivity in the work that is currently going on. Next slide. In order then to transition into equity-specific work, we had the privilege of running a pilot. It was getting started in 2018, 2019, and it's still, they're still meeting on occasion, but this is really where the roots of this, these efforts took place. And how do we move beyond implicit bias training? This was never meant to be a checky box. It's the floor, not the ceiling. So there's a lot more that needs to be done. So the CDC has the Hear Her campaign that a lot of our birth equity pilot folks tuned into, really they thought a lot about instilling accountability. On the right-hand side of this slide, you'll see one of the examples of the promise document from Sutter, from Altabates, one of our pilot hospitals, where there's a commitment when people come onto the unit that the staff is making. All the hospitals are looking at their data in a stratified fashion and then thinking about how do we change unit culture. And it has to start at home. You have to clean up your own house first, my mom used to always say. So we do the culture of equity survey to understand what's going on amongst the staff, and then we go on and think about what's happening with the patients. Also, they worked a lot on microaggressions and thinking about how do we train people to be upstanders? How do we capture the experience of people who are impacted from microaggressions? And let me just say, that is real. And it doesn't even stop happening when you're 20 plus years into your career. I mean, I was on labor and delivery just a couple months ago on a per diem basis now that I have left full time in the Permanente medical group, and I was doing handoff with the night doctor, and the charge nurse was there. The three of us were standing together, and she looked at him and said, "Hi, Dr. So-and-so," and looked at me, who she'd never met before, white coat on, stethoscope, big doctor badge, and looked at it and goes, "Hi, Amanda." And, you know, there are plenty of nurses who call me by my first name, but I have never met this woman before. And she looked at my male colleague and called him Dr. So-and-so and called me Amanda. And what she didn't know was I hired him and that he's about 5 minutes out of residency. And he still has a hard time calling me Amanda. And it's these little things that just wear people down. And in fact, I did, after the fact, not in the moment, come back to her and say, "Hey, I don't know if you noticed that you called Dr. So-and-so, and called me Amanda when you were addressing the two of us who are, you know, peers, relatively speaking, handing off for the day." And she goes, "Oh, no, I never call doctors by their first name." And I paused and I said, "Well, you know, that's actually worse because that means you didn't even see me as a doctor." So anyway, I tell that story just to say that microaggressions are real and they keep happening. And those are the little things that are real pain points in people's day. And you think about if that's happening to our professional colleagues, how are our patients then being treated? Next slide. So thank you to our pilot hospitals who gave us their hearts and blood, sweat, and tears to helping move some of this work forward. And we are really excited that the speaker following me is going to be one of the pilot leaders to talk about her experience in leading that work at Miller Children's. But before we go on to that, let me tell you about a few other tools that are going to be available for our member hospitals. Next slide. So the Culture of Equity survey that I was talking about, that is going to be launching this fall. And it's a way of creating a baseline and assessing what is the culture like on your unit vis-a-vis equity. So it is a organized, systematic way of looking at microaggressions, bias, racism, and the comfort addressing them on your unit. Next slide. Another one of our tools that's going to be launching in just the next couple months is the Hospital Action Guide for Respectful and Equity-Centered Obstetric Care. And if anyone can come up with a cool, catchy acronym, I would love it. We tried really hard to come up with one that captured all of these concepts. So please share if you come up with it. But we wanted it to be action-oriented. It is aimed at hospitals. We want patients to be being treated respectfully, and it has to be centered in equity in obstetrics. And so this guide will have 6 different modules that will help bring resources to you and tools to you if you are doing this work at your site. Next slide. And then the last piece of our puzzle is a CDC-funded learning initiative, which is sort of in our CMQCC collaborative style to help decrease the disparities in NTSV C-section rates. So we're looking at supporting vaginal birth through an equity lens. So we have different cohorts of hospitals that will be coming through. Our first 2 hospitals have been signed up. Our first 2 cohorts have been signed up already, and we are launching next month. And we're super excited to work this process and use the tools from the Hospital Action Guide and the Culture of Equity survey to help hospitals move the needle in terms of disparities, in particular using C-section rates as an outcome measure. So there's lots that we have to support you, but I want to turn it over now to Reverend Candace, who is going to talk about what was it like to actually do this work in their hospital. So the leaders can come together, we can talk, we can put these plans together, but when the rubber hits the road, we want to know, how did it go? So thank you for the work that you've done, Dr. Candace, and for your collaboration here as well.
Thank you, Dr. Williams. So appreciate all the work that has gone on. Well, good afternoon to everyone. And it is truly a blessing to be in this space with you, sharing on this very important topic of birth equity. Thank you for your presence and just being attentive to these important and valuable subject matters. As we continue, I want to frame my presentation in a story motif and invite you to journey with me on this very important journey. So let's begin. Next slide, please. We were honored to be invited to be part of the pilot collaborative. We knew that this work could be transformative because we were building a toolkit for hospitals around the nation. It was supposed to be very transformative. We were encouraged to start right where we were together. And we really did feel that we were not alone. And that's very important when you're doing hard work like this. Next slide. We reported out at our monthly sessions, all 5 hospitals. We were provided our data to start, stratified by race and ethnicity from CMQCC. And then our initial educational opportunity with all our staff was to go ahead and share the equity terms and definitions internally. We anticipated the conversations would start, and boy, did they start. And then we initiated our new patient-reported experience metric survey with our patients. Next slide, please. And so we created an internal survey to assess the climate and how our staff understood the equity terms and how they were perceiving the birth equity as we were doing the work. We kind of had fun with it. At each nursing station, we left a decorative survey box with chocolates for everyone who completed the survey. So as you can imagine, we had a lot of takers because we had a lot of people that love chocolate. Then we completed the bias training by diversity science, which some of our staff members voiced mixed feelings about that. Some thought it was a slant toward nurses, and then others thought the training was spot on and very appropriate. Next slide. And so this is the story from the survey of our culture. There were many responses, and so I just want to share a couple with you. Some nurses said, it's about time we're doing something about this. I'm so thankful to see it. Another nurse said, I have to admit, I've been challenged with my implicit biases, and I really have to do some inner reflection, some inner work. Thank you for the education and the terms listed on our EMB boards. And we place those terms in both our mother-baby units and our L&D units. Another nurse said, why are we doing this? I'm not a racist. I treat all my patients the same. Another nurse said, what about me? I've been treated unfairly and discriminated against as a white person. And one person said, thank you. What can I do to help? Next slide, please. I love a good quote. Accountability is the glue that ties commitment to the results. Next slide, please. So this is our story of becoming accountable. We partnered and implemented A1's Respectful Maternity Care Toolkit. And we were pleased to see the interest in both our mother-baby and L&D nurses to represent the respectful maternity care philosophy. And so we're happy to report that we have 10 RMC champions, and they completed their online training, signed their commitment statements, and off they went to spread the news about the RMC toolkit. Now, their roles included being available to educate staff in respectful maternity care and to answer any questions about implicit biases or concerns of equitable care. Also, their other responsibilities were to encourage many of our nurses to sign the commitment form to giving respectful maternity care and selecting a badge. And we're very happy with the percentage of most of our nurses being on board. And now these badges were very fashionable, but they also meant something very real and vital. There's 5, I want to name them for you. I commit to treating you with dignity and respect. I commit to listening with empathy, not only to respond, but to understand. I commit to shared decision-making. I commit to providing evidence-based care, and I commit to advocate for you. Next slide. Another good quote. Solidarity is not the same as support. To experience solidarity, we must have a community of interests, shared beliefs, and goals around which to unite, to build sisterhood. Support can be occasional. It can be given and just as easily withdrawn. Solidarity requires sustained, ongoing commitment. Next slide. So, a very important question. Why do we work through the tension? 1, it's honorable work. And it's really our professional role. And we need to sit and listen to our patients. It's hard work. And it's not optional work. We must do the work. And next, it's heart work. And I'm going to remind you at the end of this presentation about the heart. Next slide. And so our clinical leads and colleagues invited us each month as we gathered to present concerns, questions, experiences. And they created a safe space for us to have those discussions and process those experiences. We were fortunate to have access to our peers who oftentimes had similar experiences and challenges that they had already worked through and was very open to sharing those outcomes and those interventions. We truly operated in solidarity all the way to the end of our collaborative. And then the safe space was present to facilitate our ability to discuss racism without apology. And that's huge. Members were vulnerable, transparent, seeking to understand and also to be understood. We were not surprised that each cohort had their fair share of what we call the denialist amid their staff, those that didn't feel the work was warranted in spite of the facts. Next slide. And so as we conclude this journey, I want to invite you to answer or actually reflect on a very important question, because this is very emotional work. It's hard work. Why is it so hard? And why is it so important to do birth equity work? I want to invite you, if you're comfortable, to close your eyes while I read these reasons. It's important because to compassionately listen to the concerns of Black mothers birthing babies is respectful. To be shaken by the historical data of maternal mortality and infant loss is empathic. To understand how social determinants lead to healthcare disparities is educational. To consider one's own implicit biases illustrates personal humility. To understand that there is a clear link between racism, mistreatment, and poor maternal fetal outcomes is truth. To proactively change nursing philosophies, to integrate an equity lens is extraordinary. And finally, to have the audacity to want to change structural racism in healthcare, one hospital at a time, one obstetric unit at a time, one patient at a time, in order to transform our world is possible. Now let's listen to the hearts of our Black mothers birthing babies, and let's beat structural racism together. Final slide. Birth equity summons us to put heart in healthcare. Honor Black mothers birthing persons. Empathize in light of their lived experiences. Advocate to ensure equity. Reimagine respectful maternity care. Trust must be rebuilt. The work itself causes deep emotions, as it should, with Black babies going home too often without their mothers and fathers to raise. We must continue the story and the journey. Thank you.
Thank you. Thank you, Reverend Candace. Thank you so much for your dedication and for all of your work and for reminding us why this work is important. I would be remiss if I didn't thank the CMQCC team for all of their hard work in bringing our equity journey forward. And I also want to thank everyone who has been working on breaking down structural racism over the decades. This work is hard, and we are honored to be working alongside you. Next slide. None of us can do this work alone. It will take all of us joining together to realize the change that is part of our collaborative journey together. Many are already working on addressing inequities and outcomes, and pictured on the screen are all of the partners and stakeholders that CMQCC is collaborating with. Thank you for joining our collaborative and being part of the journey. Together, we're stronger. Next slide. So what's next? Look for today's slide and webinar in the next week to share with your colleagues that were unable to join the call. Please look for the evaluation that will be coming your way in 48 hours. We want to hear from you. We want to know what you are facing. We want to know your feedback, because your words, your information will help shape our equity journey together. Next slide. We often hear that it's hard for hospitals to understand, where do you start in this big journey? So we have a few recommendations for those that are just starting their journey. We have outlined 5 steps, and we believe that the number 1 step is to build your internal equity team. Many hospitals have launched large hospital DEI teams, but we believe that you need your own internal unit team to really begin this work. Look at your data. There was lots of data represented on the call today, and you have stratified data at your fingertips. Get curious about the populations your hospital is serving and figure out who is being left behind. We are going to be talking in August about a baseline assessment and how to conduct that. So start talking about a SWOT analysis and preparing for the work ahead. And then join us in August for a deeper dive in conducting a baseline assessment. Take the 21-day challenge. We did this as a team at CMQCC, and it was amazing to learn and to be in dialogue with the team about past racial inequities, and to really learn more about ourselves and each other when it comes to equity and the change that we want to see in ourselves and in the world. And then register for upcoming webinars. You can go to cmqcc.org and please join us by registering for upcoming webinars. That will ensure that you're getting the most up-to-date information and connected to webinars going forward. Next slide. So as I mentioned, join us in August and then look for us on social media. We are relaunching our social media presence and hope to have a unique following by many, many partners and stakeholders across the state. Last slide. Thank you for joining us. We know the work that we do together to end inequities in birth outcomes. It can't wait. Sadly, the reality is moms and babies are dying, and they're counting on us for help. And I get emotional about it because I can't imagine facing death, the death of my child or the death of my sister. It's going to take all of us working together, and I thank all of you. I thank you for taking a step forward to being the change that we want to see in the world and in California and beyond. Together, we can achieve the vision that we have for ourselves and for our state, and that's ensuring that we have equity for all birthing persons that are delivering in our hospitals. So thank you for joining us. Thank you for being here with us and being part of our collaborative. We look forward to seeing you soon. Good night, goodbye, not good afternoon.